A very good evening, friends, and welcome to the 20th webinar, which is on a very, very important topic of arthritis and uveitis. I received the feedback from the last webinar, and I was very touched to see so many tributes to Manfred. And I think the best tribute that we can pay to Manfred is to continue the series and to work in the field of uveitis as he would love all of us to work. With this, I would like to invite our first speaker, which is Claudia Fabiani, who's doing an amazing work in uveitis, autoimmune diseases, arthritis. And Claudia is going to speak to us about differential diagnosis of uveitis and arthritis. Over to you, Claudia.
Thank you. I'm going to share my screen. Can you see my slides?
Yes, Claudia, yeah, we can.
I thank the organizers for giving me the opportunity to be part of this extraordinary youth educational program. Uveitis is the most common clinically important extra-articular manifestation of several immune-mediated diseases. At least 15 distinct rheumatic diseases can involve both the joints and the uveal tract. Ankylosing spondylitis and its closely related spondyloarthritis are the most commonly diagnosed systemic diseases associated with uveitis in North America and Europe. As many as 50% of patients with ankylosing spondylitis experience the development of uveitis during their lifetime, with a progressive increase in acute anterior uveitis penetrance with disease duration. The concept of spondyloarthritis or SPA comprises not only ankylosing spondylitis, but also psoriatic arthritis, arthritis spondylitis with inflammatory bowel diseases such as Crohn's disease and ulcerative colitis, and reactive arthritis. Patients with typical features of SPA that do not fulfill the criteria for one of these subtypes have also been incorporated in the SPA concept as undifferentiated SPA. Regarding pediatric patients, uveitis and arthritis characterize some forms of the wide disease family of juvenile idiopathic arthritis, and among monogenic autoinflammatory disorders with pediatric onset, Blau syndrome comprises in its well-known triad of signs, uveitis and arthritis, in addition to the peculiar skin rash. The reason for the coexistence of uveal inflammation and joint inflammation in different multi-system diseases is unexplained, although some compounds such as hyaluronic acid, type 2 collagen, and agrecan are common to both the eyes and the joints. Uveitis and arthritis also occur together in several animal models, such as SKG mouse, in 2 different strains of rats following intradermal administration of Freud's adjuvant containing Mycobacterium butyricum, and agrecan-induced arthritis in bulb C mice. The coexistence suggests a shared pathogenesis, but for example, in the agrecan model, mice which do not produce gamma interferon develop more severe uveitis, while the arthritis is dramatically ameliorated. This means that further work needs to be done to clarify the role of specific genetic and environmental factors that contribute to the development of uveitis in a subset of patients with seronegative arthritis. Indeed, ankylosing spondylitis and acute anterior uveitis share a variety of predisposing genes, such as the HLA-B27, the IL-23 receptor, and ERAP1, But at the same time, there are identifiable genes such as IL-6 receptor, probably IL-10 and IL-18R1 that seem to influence solely the susceptibility to acute anterior uveitis. HLA-B27 itself is considered an acute anterior uveitis risk gene, regardless of whether or not ankylosing spondylitis is present. Regarding environmental factors, we know that we share our bodies with 100 trillion bacteria, the so-called microbiome. Gut commensal microflora or specific classes of pathogens may be instrumental in the initiation of inflammatory arthritis and uveitis through bacterial translocation, antigenic mimicry, or leading to alterations in regulatory and effector T cells. Nowadays, data support the concept that HLA molecules shape the microbiome and in turn predispose to acute anterior uveitis, spondyloarthritis, and inflammatory bowel diseases. Moreover, HLA-B27 transgenic rats do not develop SPA in a germ-free environment. And interestingly, the laboratory of Rachel Caspi has studied a transgenic mouse whose intestinal bacteria can activate selectively the retinal-directed T cells. In this experimental model, inflammatory reaction is markedly ameliorated by either broad-spectrum oral antibiotics or raising the mice in a germ-free environment. Therefore, the antigenic mimicry theory showed strong support in the lab, although the actual bacteria responsible for the mimicry have not been identified. However, we also know that there are specific enteric infections like Salmonella, Shigella, Yersinia that trigger reactive arthritis, especially in susceptible people positive for HLA-B27. And we also know that non-gonococcal urethritis is a clear trigger for reactive arthritis in HLA-B27 patients. These all seem clear demonstrations of the interaction between genetic and environmental factors in an inflammatory rheumatic disease, and they might explain how inflammation of the joint may be stimulated by microbial antigens at a remote site in the body, and suggest the idea that interaction between host and microbe is somehow abnormal and inefficient in HLA-B27 positive subjects. But which are the typical features of uveitis related to SPA? Most SPA B27 positive cases, usually 30-40 years old men, have the classic non-granulomatous anterior uveitis, namely acute or recurrent acute, unilateral or unilateral alternating. The inflammatory attack is characterized by an intense anterior chamber reaction with numerous cells, a fibrin spiderweb visible in the pupillary area, a strong tendency to synechiae, and low intraocular pressure. Occasionally, in about 10% of cases, hypopyon might be detected, which need to be differentiated by the hypopyon typical of Behçet disease uveitis. Indeed, the eye of a patient with ankylosing spondylitis and hypopyon is red, tender, and sensitive to light. Fibrin is frequently present in the anterior chamber with a strong tendency to synechiae. In contrast, hypopyon in Behçet disease uveitis is not associated with pain or intense redness. Fibrin is rarely present, and the hypopyon may change position with that movement, and it may form and disappear rapidly without sequelae. However, we must take in mind that about 15% of patients in the SUN database of HLA-B27 positive anterior uveitis are reported having a chronic uveitis upon presentation, a result seen in other large cohorts of patients with SPA. In addition, several cases in this SUN database have a history of classic pattern that evolved over time into a chronic uveitis, a phenomenon which has been described previously. In addition, patients with psoriatic arthritis were noted to have more likely an atypical SPA-associated uveitis. In this regard, several studies have attempted to characterize the uveitis among patients with psoriatic arthritis. A study on 16 adult patients affected by psoriatic arthritis and uveitis Paiva and colleagues found that an insidious onset of the uveitis, chronic course, bilateral and posterior eye disease were more common in association with psoriatic arthritis and inflammatory bowel diseases compared to the typical HLA-B27 associated uveitis noted in patients with ankylosing spondylitis. A Spanish study also noted that bilateral uveitis and an insidious onset could be present in association with psoriatic arthritis in more than 30% of patients. These results indicate clearly that many patients with uveitis in association with psoriatic arthritis have eye disease that can be distinguished from that associated with ankylosing spondylitis, and that the uveitis associated with psoriatic arthritis is more likely to begin insidiously, to be continuous, bilateral, and posterior. Regarding gender impact, current data suggests that male patients with psoriatic arthritis tend to develop uveitis that is more similar to that present in ankylosing spondylitis, and female patients with psoriatic arthritis tend to develop peripheral arthritis and uveitis more typical of inflammatory bowel diseases, as says bilateral, posterior, with insidious onset and or chronic in duration. On the other hand, a Japanese study of 13 adults and an Italian study of 23 adults with uveitis and psoriatic arthritis found that all but one had acute anterior uveitis. Less is known about juvenile onset psoriatic arthritis and the uveitis that may accompany this diagnosis. Findings from a small case series suggest that children with psoriasis or psoriatic arthritis that begins by age 6 or younger can suffer from a bilateral, chronic, anterior, and or intermediate uveitis that is particularly severe, such that biologic therapy was prescribed for all patients in this series. The observation suggests that the uveitis that accompany juvenile psoriatic arthritis might be a distinct disease, which is particularly severe when its onset affects children age 6 or younger. More in depth in the pediatric age uveitis differential diagnosis, juvenile idiopathic arthritis is the most common cause of uveitis in children, accounting for about 50% of all types of uveitis seen in children. JIA is defined as arthritis of at least 6 weeks of duration without any identifiable cause in children younger than 16 years. Uveitis typically presents after arthritis develops, but in 3–7% can have uveitis develop before arthritis. Approximately 20% of children with oligoarticular JIA develop uveitis, while polyarticular onset JIA patients experience uveitis at a lower rate, about 5%. African American children are more likely to be diagnosed with enthesitis-related JIA. Of those who will develop uveitis, over 90% do so within 4 years of diagnosis of joint disease. Uveitis related to enthesitis can present more similar to the adult SPA-related acute anterior uveitis counterpart, and therefore is more common in HLA-B27 male patients, is usually very symptomatic, characterized by red eyes, photophobia, pain, blurred vision. On the other hand, chronic anterior uveitis, mostly related to oligoarthritis in very young ANA-positive female, is characterized by lack of symptoms. The eye is typically white. The activity of this usually bilateral non-granulomatous chronic and insidious uveitis is detected by counting anterior chamber cells. Given the insidious nature of these chronic anterior uveitis, without appropriate screening, it is not until the appearance of the first complication of uveitis that their relatives or the physician during a routine examination detect its presence, resulting in delayed diagnosis and treatment. Indeed, ocular screening examination is vital for these at-risk patients subject to asymptomatic vision loss. Screening guidelines continue to undergo revision, but are based on specific risk factors and clinical biomarkers for developing uveitis, the presence of oligoarthritis, female gender, ANA positivity, the onset of arthritis before 4 years old. Of note, as psoriatic arthritis, polyarticular seronegative, and enthesitis-related uveitis might be asymptomatic as well, those children should be also screened. Same for idiopathic chronic anterior uveitis. Sometimes misdiagnosed as JIA uveitis that can present, although very rarely, as granulomatous uveitis. The so-called JAB syndrome or Blau syndrome is a monogenic autoinflammatory disorder. The presence of the typical bilateral panuveitis with multifocal chorioretinal lesion and disc abnormalities associated with arthritis and the typical skin rash in very young children raises the suspicion of Blau syndrome that can be confirmed by a biopsy of affected tissues or genetic testing. Among the group of monogenic autoinflammatory disorders, several syndromes comprises in their clinical picture uveitis and arthritis. For example, both are present in patients with VEXAS syndrome, familial Mediterranean fever, CAPS, and so on. Together with Lucia Sobrin from Harvard University and Luca Cantarini from University of Siena and co-leading a group of interest of the International Uveitis Study Group focusing also on genetic syndromes causing uveitis, the genetic and uveitis group of interest. Please feel free to join because I believe that we all can learn a lot from monogenic diseases. To overcome the fragmentation of clinical and research experience of inflammatory ocular diseases also related to arthritis, several AIDA international registries are available for collecting demographic, genetic, clinical, and therapeutic data regarding adult and pediatric patients. Any clinician dealing with inflammatory ocular diseases such as uveitis is welcome to join in the AIDA network and start sharing data and carry out solid research based on a large number of patients. To date, 135 clinical sites from 27 countries from 5 continents have already joined the network and are actively enrolling patients into the registries. The activities of the AIDA network are detailed on our website. To conclude, further work needs to be done to clarify the role of specific genetic and environmental factors that contribute to the development of uveitis in different subsets of patients with arthritis. International registries such as the AIDA registries will allow to better define the clinical picture of uveitis and their related arthritis. Ophthalmologists must be aware of typical and atypical presentations of each type of uveitis related to arthritis and differential diagnosis both in the adult and pediatric patient. Multidisciplinary approach and close collaboration between ophthalmologists and rheumatologists and pediatric rheumatologists, preferably through combined consulting, is mandatory for early referral, efficient diagnostic workup, proper treatment strategies, and research purposes. Thank you for your attention.
Thank you very much, Claudia. And thank you for that very clear message that we need a very close association between pediatric rheumatologists, as well as the uveitis expert. And with this, we now move on to our next talk by Kalpana Babu Murthy. She will be talking about ocular complications of rheumatoid arthritis and ankylosing spondylitis.
Thank you, Dr. Vishali. I will just share my screen now. Am I audible? Am I audible?
Yes, ma'am.
All good.
Hello.
Yes, Kalpana, it's clear. Go on.
Okay, so I'll go on. So at the outset, I would like to thank Dr. Vishali and the IUSG for this invitation to be a part of this webinar. And my talk will be on ocular complications seen in rheumatoid arthritis and ankylosing spondylitis. Before I start, I would like to acknowledge my colleagues in the rheumatology side who have been with me so many years treating these patients with ocular complications as well. So to start off with, rheumatoid arthritis is the most common systemic autoimmune disease, which is usually seen in 1% of the general population. And this is associated with inflammation of the synovial membranes of the joints, which results in destruction of the joint and deformities. This is 3 times more common in women, with 80% being between the ages 35 and 50 years. Ocular involvement is an extra-articular manifestation of rheumatoid arthritis, and generally patients with high titers of rheumatoid factor are likely to have extra-articular manifestations. The cause of rheumatoid arthritis is unknown, but what we do know is the pro-inflammatory cytokines secreted by the macrophages, such as the TNF-alpha, interleukin 1 and 6, play a critical role in the induction and propagation of chronic inflammation in rheumatoid arthritis. So let's look at what are the structures involved in the eye in rheumatoid arthritis. It generally involves the front part of the eye and can cause keratoconjunctivitis sicca, episcleritis, scleritis, anterior uveitis, and peripheral ulcerative keratitis. Rarely, it can involve the back portion of the eye, causing posterior scleritis and retinal vasculitis. Sometimes the drugs which we use to treat the systemic disease can cause ocular involvement in the form of cataract and glaucoma and HCQS-related retinal toxicity. Usually, the ocular involvement occurs during the course of the disease in rheumatoid arthritis, but sometimes can be an initial manifestation of rheumatoid arthritis. So let's look at keratoconjunctivitis sicca. This is the most common ocular manifestation of rheumatoid arthritis, occurring in 18 to 90% of patients, depending on multiple studies, out of which up to 50% exhibit moderate to severe symptoms. The type of dry eye which we see is the mixed type, and the patients usually complain of ocular discomfort, visual disturbances, tear film instability, increased tear osmolarity, increased inflammation of the ocular surface, and damage. The basic cause is inflammation. So this is how the dry eye looks. They have an increased staining of the ocular surface. You can have filamentary keratitis, sometimes even mucus clumping. They have this conjunctival hyperemia and increased osmolarity. Long-term complications include keratitis, like in this case, opacification of the cornea, and even paracentral corneal melts and even perforation. So how do we treat these patients? One, we can optimize the environment around them, and lubrication. This is both in the form of supplementation as well as retention in the form of punctal occlusions, moisture chamber goggles, overnight gels, secretagogues, etc. But since the basic cause is inflammation, they generally do well with local and systemic anti-inflammatory therapy. And the local therapy is in the form of topical cyclosporin eye drops. Let me share with you one case. This is an advanced joint disease. The other eye had no perception of light, and the left eye had extensive corneal surface disease with anterior uveitis and cataract. She had a very turbulent postoperative period with severe conjunctival hyperemia, ocular discomfort, mucus plugs, filaments, and even a decimatocele. And eventually she did well with extensive lubrication, increasing the systemic immunomodulation, and she required a therapeutic soft contact lens fit, and she's been relatively comfortable with a fairly good amount of vision. Episcleritis is the second most common manifestation of rheumatoid arthritis, occurring in 1 to 5% of patients. It can occur at any stage, more common in women. Generally, episcleritis in rheumatoid arthritis is bilateral and recurrent. It can be self-limiting, but sometimes may require oral systemic immunomodulation. Now, this is an interesting case. She's a patient with rheumatoid arthritis, 7 years duration, and she was on immunomodulation systemically. Unfortunately, she couldn't afford biologics, so she was still on a maintenance of oral steroids with injection methotrexate, leflunomide, and HCQS. But she had this episcleritis tuft, which would settle down with topical steroids, and once the topical steroids were stopped, she would get it back. And eventually, she developed glaucoma. So since this eye also had a cataract, her systemic arthritis was under control. So on discussion with the rheumatologist, we thought, let's give her intravenous cyclophosphamide pulse doses. And this is how her eye has been after cyclophosphamide. And now I've been maintaining her with oral methotrexate, and she's still doing very well with no recurrences at all. And she's had a successful cataract surgery even. So scleritis is another important complication of rheumatoid arthritis, and it is one of the most serious because it's extremely painful and it can be potentially blinding. This can occur in 1 to 6% of rheumatoid arthritis, and generally it is the anterior scleritis. Very rarely you can have posterior scleritis, and it can occur with chorioretinal granulomas, chorioretinal folds, optic disc edema, and retinal vasculitis. There is a small subset of scleritis which is necrotizing, and these are associated with increased mortality. Generally, scleritis is seen more than 10 years after the onset of arthritis, and most of these patients also have advanced joint disease, but sometimes it can be an initial or the presenting manifestation. The mortality rate is higher in patients with rheumatoid arthritis who have scleritis, and especially the necrotizing type. And these patients require systemic immunomodulation, either conventional immunomodulation like methotrexate, and if they fail this, they will require TNF antagonists, rituximab, and even cyclophosphamide. So these are the different manifestations of scleritis in rheumatoid arthritis. And there is a small subset called the scleromalacia perforans, where there is a progressive thinning of the sclera. And these patients do not exhibit redness as in these cases. Another dangerous complication of rheumatoid arthritis in the eye is peripheral ulcerative keratitis. This is extremely rare, and this is associated with longer duration of the rheumatoid arthritis. And here there is a destructive inflammation of the juxtalimbal corneal stroma associated with an epithelial defect, and it is potentially sight-threatening. The trigger is usually an infection, or it could be a non-infectious cause such as a surgical insult. These patients are associated, there's an increased mortality in these patients, and they require aggressive systemic immunomodulation. Let me share with you a case. This is a 72-year-old lady with RA, and she presented to us with this kind of a peripheral ulcerative melt. And she had a similar issue 2 years ago post-cataract surgery. So the first thing we do when we see something like this is to rule out infection, and she underwent a biopsy, and that was negative for infection. Cyclophosphamide is dicey at this age, but we did go ahead with IV methylpred and IV cyclophosphamide. But during the course, she developed secondary infection, and we had to eventually stop cyclophosphamide. But the inflammation started getting better, and this was her final picture 4 months down the line. Anterior uveitis is rare and usually seen in patients with advanced joint disease. However, we do see low-grade anterior uveitis, which is recurrent, especially post-surgical procedures such as cataracts. Retinal vasculitis is serious and a potentially blinding condition, but it is rare, and this also requires aggressive immunomodulation. Apart from cataract and glaucoma, which can occur because of the oral steroids, HCQS can cause retinal toxicity, and this is duration dependent. So we usually screen them at baseline, and after 5 years, they are screened annually or sooner if they have major risk factors. And we generally do visual fields and spectral domain OCT. Coming to the next disease, which is ankylosing spondylitis, this belongs to the group of spondyloarthritis. And the most common extra-articular manifestation of ankylosing spondylitis is uveitis. So this can occur in up to 50% of these patients. And there is a significant association with HLA-B27. Nearly 90% are positive for the same. Occurrence of uveitis increases with the duration of spond, but sometimes it can be an initial manifestation of a systemic disease. And generally, patients who have uveitis have a higher disease activity and a greater radiological damage. There are significant associations with HLA-B27, IL-23R, ERAP1, and intergenic region 2P15, as discussed by Dr. Claudia in the earlier talk. So how does this uveitis, what are the typical characteristics of uveitis in ankspond? This is generally anterior. Males are more commonly involved, and the first attack is usually between 20 and 45 years. They are most of the time unilateral, or they can be unilateral alternating, which is characteristically called the flip-flop. Very rarely, it is bilateral. This uveitis comes with a sudden onset. There is a 1 to 2 day prodrome with pain before the cells are seen in the anterior chamber. The uveitis is recurrent and there is a pain for near distance activities, and this is because of the associated cyclitis. Generally, it resolves within 2 to 3 months. Triggers could be in the form of infections, stress. Sometimes they say in particular seasons, and trauma. The uveitis recurrences are usually unrelated temporally with activity or severity of the underlying SPA. Now, the type of uveitis which we see in angstpond is in contrast to that we see in other types of spondyloarthritis. So we generally see circumciliary congestion. The patient usually has redness, pain, and photophobia. This is the capes which are in the form of endothelial dusting, and these patients usually have low intraocular pressure at the time of activity. Sometimes it can be very severe in the form of hypopyon. You can have fibrin, and with time, the frequency of the anterior uveitis comes down, and they may not have redness or pain, but they can just come with blurring of vision, as in this patient. It can also be very severe, and you can see hemorrhages in the hypopyon or in the fibrin. Other complications which can occur are posterior synechiae, and that is the reason why we treat these patients aggressively with topical steroids and cycloplegics. You can have glaucoma, which could be either due to pupillary block or because of the steroids which we use to treat the inflammation. Similarly, you can develop cataract. Rarely you can have corneal decompensation in recurrent and chronic cases, and scleritis is a very rare complication of B27. Posterior segment manifestations are generally overlooked in angstpond-associated uveitis, and this could be in the form of cystoid macular edema, which could come in 2 to 3 weeks of initial presentation. You can have retinal vasculitis. This could be clinically evident as occlusive vasculitis, or on the FFA, you can see this peripheral retinal vascular leakages. It can come as vitritis, optic disc edema, pars plana exudates, and epiretinal membranes. This is very rare though. Let me share with you one case. Actually, she was on injection methotrexate, tacrolimus, and oral steroids maintenance dose. And her C-reactive protein was still on the higher side. And she came with sudden drop in vision in her right eye. And if you can see a trace hypopyon, severe anterior segment inflammation. And posterior segment, she had vitritis and even clumps of exudates. So at this point of time, it was difficult to say whether there was infection or this was a part of the spectrum of B27-related uveitis. So she underwent an AC tap, which was negative, and she was treated with biologics, and this is the result. The drugs which can be used to treat ankylosing spondylitis can also cause uveitis in the eye, as in this boy who was on etanercept, and this is known to cause induced uveitis, and eventually he was shifted to adalimumab. And in patients receiving infliximab, especially in high TB endemic countries, there could be reactivation of tuberculosis, and we have seen tuberculosis-related uveitis in the eye as well. This is an interesting case which I saw recently. A young lady who was on adalimumab for the systemic disease, and 2 months ago, she was shifted to tofacitinib. And once she was shifted to tofacitinib, she started having episodes of blurring of vision in the right eye. The rheumatologist who was treating her told us that her systemic disease was under control. She had no recent vaccinations and she was a non-smoker. But we saw something like an impending vascular occlusion. There were hemorrhages, collaterals, rot spots, hemorrhages in the posterior pole. The patient was attributed the whole thing to the new drug which she was on, and she stopped it by herself. And we saw her a week later because we had ordered it for the labs. By the time she came back to us a week later, her vision had improved, symptoms were much better, and her labs were all normal, both hematological and the autoimmune profile, including the APLA and ANA. So since she was already getting better, a fluorescent angiogram did not show much of a leakage except for a peripheral leak. And we just stepped up her methotrexate, and she was only on injection methotrexate. And this was 2 months later. Her vision had improved to 6/6, and all her features had more or less disappeared except for the collaterals. It is important to remember tofascitam has thrombogenic effects, and we should be careful when we are using this drug in our patients. Though the initial presentations are very aggressive, these cases are usually associated with excellent visual outcome if they are on good immunomodulation. And even cataract surgery, these patients do very well if there is a good pre- and post-operative control of inflammation. As I had mentioned earlier, there could be an underlying systemic disease, and the presentation of uveitis actually should help us look out for underlying disease. And this duet algorithm is quite useful so that these patients can be timely referred to the rheumatologist. So to conclude, both rheumatoid arthritis and ankylosing spondylitis have sight-threatening ocular complications, and it is important for us to diagnose them early and treat them promptly. I cannot overemphasize the need for a close collaboration between a rheumatologist and ophthalmologist in treating these patients. I thank you all for the patient hearing.
Thank you very much, Kalpana. So now we know how important the rheumatologists are, and the next 3 talks are by the world-renowned rheumatologist, starting with Jim Rosenbaum, who will be speaking about systemic vasculitis, arthritis, and retinal vasculitis. Jim will be joining us shortly. His talk is recorded. So can we play his talk, please?
Hello, my name is Jim Rosenbaum, and I'm honored to have the opportunity to participate in this IUSG webinar. My topic is systemic vasculitis, arthritis, and retinal vasculitis. And I must tell you that I did not create this title, and the term arthritis in this title is quite misleading, in my opinion. I'm a rheumatologist, and a rheumatologist, of course, is an internist, and internists adore the journal, the New England Journal of Medicine. It is iconic. And almost every week, the New England Journal includes a case record. Back in 2005, it included a case record of an individual who had a severe retinal vasculitis, as shown in this fundus photograph and shown in this fluorescein angiogram. This patient also had palpable purpura, and palpable purpura is usually indicative of a small vessel vasculitis in the skin, and it can be seen in polyarteritis. The discussant, the ophthalmology discussant in this case, wrote, in this patient with predominantly arterial involvement and a systemic illness without evidence of infection, my leading diagnosis based on the ocular findings would be polyarteritis nodosa. The discussant was absolutely correct, but the discussant provided a reference, which was a case report. Polyarteritis is in the differential diagnosis of retinal vasculitis, but to my knowledge, there are a total of 2 case reports in the literature, one that was cited and one that was discussed here in this case record. It is incredibly rare, and therefore it's misleading to have this as a learning case. So let me offer you my own representative case. A 40-year-old woman with ANCA-associated vasculitis is monocular from severe orbital inflammatory disease. Her systemic illness was treated with rituximab and cyclophosphamide, which is appropriate, and it was well controlled. She was maintained on a low dose of oral cyclophosphamide 18 months after the onset of the illness. Systemically, her disease was quiescent, but she began to notice some scotoma affecting her vision in the remaining eye, and so she went to an ophthalmologist who said, "Oh, you have retinal vasculitis," called the rheumatologist, and the rheumatologist then had to make a therapeutic decision. I'm going to come back to this case in just a moment. So if you learn these 3 bits of information, I will be very happy. The first is that retinal vasculitis is misunderstood when you use that term and you're speaking to a non-ophthalmologist. The second is that retinal vasculitis is heterogeneous and it is rarely subclassified. And the third, and perhaps most important, is that retinal vasculitis correlates very poorly with the presence of a systemic vasculitis. So let's compare retinal vasculitis to systemic vasculitis. We often diagnose retinal vasculitis on the basis of a fluorescein angiogram or perhaps an ICG, just showing leakage of the dye. An internist or a rheumatologist would never diagnose systemic vasculitis on the basis of vascular leakage. If that were the case, every individual with pedal edema would be diagnosed as having a systemic vasculitis. The vessels that are affected in retinal vasculitis are very small, almost microscopic, whereas systemic vasculitis could involve a large vessel, could cause an aortitis, could involve a small vessel, as in a leukocytoclastic vasculitis in the skin. It's quite variable. And in fact, we make the diagnosis in part on the basis of the size of the vessel that's being involved. Retinal vasculitis is virtually never diagnosed on the basis of a biopsy or histology, occasionally, but that's very rare. Whereas the most likely way that we would diagnose a systemic vasculitis is by histology, and imaging would be occasionally the way that this diagnosis would be arrived upon. So you need to remember that vessels in different beds are different. They have different cell surface molecules on the endothelial cell, and there's a tropism for the disease for a specific type of vessel. For example, one of the more common forms of systemic vasculitis is called giant cell arteritis. 2 versions of giant cell arteritis are temporal arteritis and Takayasu's arteritis in a younger individual. Giant cell arteritis is obviously important for ophthalmologists because it can affect the ophthalmic artery and its branches, which include the central retinal artery. But giant cell arteritis virtually never affects intraretinal vessels. Giant cell arteritis can cause a stroke because of a watershed effect. It can affect the vertebral arteries or the carotid arteries. But in general, it never affects the intracranial vessels, just as it never affects virtually the retinal vessels. The disease GPA, which is also known as ANCA-associated vasculitis, has a predilection for certain types of vessels. IgA-associated vasculitis is another example. Any form of systemic vasculitis that you can name has a preference or a predilection for certain types of vessels. We do not do a very good job of subsetting retinal vasculitis. So retinal vasculitis could be primary, where you have retinal vasculitis and no systemic illness, or it could be secondary, such as secondary to an infection like toxoplasmosis or CMV. Retinal vasculitis could involve a vein, it could involve an artery, or it could involve both veins and artery. It can be occlusive or non-occlusive. It can be ischemic or non-ischemic. It can be central or peripheral. And if you start subsetting by some of these criteria, you find it's easier to arrive at a specific diagnosis and to appreciate the implication of the retinal vasculitis. So let's take another look at this heterogeneity of retinal vasculitis, which I think is so critical and so rarely appreciated even by ophthalmologists. Here's a paper that I helped to co-author by John Peter Campbell, who's at the KCI Institute. And he commented upon how common we see on FA peripheral vascular leakage in patients with uveitis. In fact, we see occasionally peripheral vascular leakage now that we're doing wide field ophthalmoscopy and wide field photography in individuals who apparently are perfectly healthy. And we're still debating the implication of this peripheral vascular leakage. Do we need to treat it? It usually doesn't affect visual acuity. Is it just a curiosity, or does it really tell us something about the disease? This is a patient with CMV, and I think you'll all recognize this kind of whitish necrosis as indicative of CMV. And I don't think anyone would debate that this is a retinal vasculitis. Here you see some sheeting, and here you see intraretinal hemorrhage. The only thing that could cause changes like this would be a retinal vasculitis. And when you hear about a patient on immunosuppression whose systemic disease is well controlled, but there's a retinal vasculitis, you should think first about infection, second about infection, and third about infection. And the representative case that I presented was indeed a case of CMV retinitis. Usually, when I've been contacted about a case like that, it's not by a rheumatologist, it's not by an ophthalmologist, it's usually by an attorney, because the rheumatologist has assumed in hearing the term retinal vasculitis that it must be an inflammation, and the rheumatologist has usually increased the immunosuppression, which of course is a disaster in the setting of CMV retinitis. Here's another form of retinal vasculitis. We would call these taches de bougie, candle wax drippings, and they're indicative of sarcoidosis. Here's another patient whom I saw once upon a time with sarcoidosis with intraretinal hemorrhage. Retinal vasculitis is rather common in sarcoidosis, but that's disconcerting to me as a rheumatologist, because sarcoidosis elsewhere in the body is not a vasculitis. It is not considered a vasculitis, and it is certainly not classified as a vasculitis. Here's a patient who's got a fundus photograph, and the fundus photograph looks relatively normal. But when you inject fluorescein, it's clear that there's vascular leakage. You can see by the pattern of the vessels, this individual with the fluorescein and this fundus photograph taken from the same individual. And yet, every ophthalmologist in the world, I submit to you, would say this vascular leakage indicates a retinal vasculitis, and that would not be the way that an internist would diagnose a retinal vasculitis. And then here's a peripheral periphlebitis. And when I see a peripheral periphlebitis in association with pars plana exudates, I think of one systemic disease in particular, and that's multiple sclerosis. Another example of an immune-mediated systemic illness, which is not a systemic vasculitis, but is associated with a retinal vasculitis. Let me take just a little bit of a detour. First of all, I want to share with you what I consider to be a classic paper from the group at Iowa. It included two very famous uveitis experts, Jose Polito and Jim Folk. And Susan Malinowski, at the time, I believe that she was either a retina fellow or a resident. She characterized pars planitis in 54 patients. And she noted that over 5 years, the risk of either multiple sclerosis or optic neuritis among those 54 patients was a little over 20%. And it went up markedly if the individual not only had pars plana exudates, but periphlebitis. This is her table that shows it, and there's a mistake in this table. She found 108 eyes from the 54 patients, and 17 of those 108 eyes had periphlebitis, but somehow that translated only to 6 individuals. That just doesn't add up mathematically, but still, it's a very important and insightful paper. Now, I showed you earlier a case report from the New England Journal, and I suggested that maybe it came to some misleading conclusions. If you'll excuse me this bit of a tangent, this was another CPC from the New England Journal about a 28-year-old woman with ocular inflammation, which was uveitis, fever, and headache. And the neurologist who discussed the fever and headache was named Marty Samuels. One of Marty Samuels's distinction is that he has discussed more case records than anyone in the history of the New England Journal. And Marty Samuels said, this is a classic case of uveitis, and he offered a brilliant differential diagnosis of uveitis, which includes things like Behçet's and sarcoid and acute retinal necrosis and various infections, and of course, syphilis and VKH and lupus and primary CNS vasculitis, lymphomas. But one of the things it doesn't include is probably multiple sclerosis. And I say probably because you can see a few cells in the CSF in multiple sclerosis, but in general, multiple sclerosis is not a likely cause of a meningitis. Here's a patient who's got retinal edema and intraretinal hemorrhage. This patient had Behçet's disease. And here's a very different photograph of a retinal vasculitis. This is an occlusive retinal vasculopathy. It's a very clear photo because there were no cells in the vitreous humor, but there's clearly intraretinal hemorrhage. There clearly are vessels that are blocked and then reconstituted. And this patient has an autoantibody, namely antiphospholipid antibodies, which we know are in the differential diagnosis of an occlusive retinal vasculopathy. So my colleagues and I wanted to better understand the relationship between retinal vasculitis and systemic vasculitis, and we published our findings a decade ago in a journal called Seminars in Arthritis and Rheumatism. We reviewed nearly 1,400 patients, and we were selective. We tried to pick patients who had a diagnosis where we thought there was a reasonable likelihood that retinal vasculitis would be present. This was not our entire series of patients with uveitis. We found that about 1 out of 7 of these nearly 1,400 had evidence for a retinal vasculitis. Now, of these 207 with retinal vasculitis, we had 14 with Behçet's disease. If you live in a part of the world like Japan or Turkey, where Behçet's is relatively common, your numbers are going to be far different from my numbers in Portland, Oregon. And I don't believe that Behçet's is primarily a vasculitis. So I took the liberty of not calling Behçet's a systemic vasculitis associated with retinal vasculitis, but I confess that if you believe that this is a systemic vasculitis, your numbers are going to be a little bit different. And if you're from Turkey, your numbers are going to be a whole lot different from my Portland, Oregon numbers. So almost 1,400 patients with uveitis. 11 of those 1,400 had a systemic vasculitis. That included 4 with central nervous system vasculitis, 3 with GPA, 2 with the disease we used to call Churg-Strauss that we now call eosinophil GPA, 1 with a pulmonary vasculitis, 1 with a cutaneous vasculitis. So remember, 11 out of the 1,390, or less than 1%, had a systemic vasculitis. But of those 11 with a systemic vasculitis, only 4 had a retinal vasculitis, and 1 of them is shown here, and her retinal vasculitis was due to CMV, which is healed in this photograph. So as a rheumatologist with a bias to get patients referred with a systemic vasculitis, I was only able to find 1.4% of patients with retinal vasculitis with a systemic vasculitis, with the provision that I have excluded Behçet's disease. It is simply not common. It occurs, but it doesn't occur very often. CNS vasculitis is one disease that you should think of. There are forms of uveitis that are commonly associated with retinal vasculitis, like birdshot shown here, sarcoid, pars planitis, and especially infections, including the herpes family infections, syphilis, TB, and toxoplasmosis. So here are the take-home messages. Patients with retinal vasculitis rarely have a systemic vasculitis. Forms of vasculitis have a predilection for specific vascular beds. Always think first about infection as a cause of retinal vasculitis. Remember that some viruses like CMV are probably vasculotropic. They love to cause vascular inflammation. Retinal vasculitis is sometimes and I would say often identified simply by vascular leakage. 2 systemic illnesses that don't cause systemic vasculitis, but are associated with retinal vasculitis, MS and sarcoid. And Behçet's is the one systemic vasculitis, if you classify it that way, that does often cause a retinal vasculitis. I'm very grateful again for the opportunity to share this information with you and for the opportunity to speak along with my distinguished colleagues. Thank you so much.
Very much, Jim. And now we move on to another rheumatologist, A.V. Ramanan, and he's going to tell us about what role the rheumatologist can play in uveitis patients. Thank you, Ram, for joining us.
Thank you very much, Dr. Vishali. It's a hard task to follow Jim, and even harder when 3 others before me have given such excellent expositions. Jim was very modest in saying he's a rheumatologist. We consider him within the rheumatology field as much of an ophthalmologist because he's probably the only one who can handle the slit lamp and the joint examination incredibly well. So if there's some overlap in what I'm going to say with the previous speakers, my advance apologies, and they probably did it much better than I could. These are my disclosures. So these are the 4 broad points, even though I've been given 15 minutes. If there's take-home message, I'm not going to finish with it. I'm going to start with it. And you've already heard from the first 2 speakers how uveitis can be the presenting feature of rheumatic diseases. And nothing gives this better than ankylosing spondylitis. And both of the first 2 speakers demonstrated that, and I'll come back to that. And of course, there are patients with rheumatic diseases who can develop uveitis, both of which augur for the importance of both rheumatologists and ophthalmologists working together in conjunction. Now, most in this audience are ophthalmologists. Most of you are probably surgical ophthalmologists, and many of you rightly may or may not feel comfortable in prescribing and modulating and monitoring immune-mediated therapies, be they methotrexate, cyclosporin, azathioprine, mycophenolate, or the new age of biologics such as anti-TNFs, anti-IL-6, and so on. And I think working with a uveitis specialist in the diagnosis and management of these conditions is integral because many of these patients are complex. And we often think of the complex patients as one with retinal vasculitis, and Jim's shown you how rare it is. But what we need for better outcomes is working together with either the internist or with the rheumatologist in delivering better care for our uveitis patients. And you had a fantastic example in Dr. Kalpana's talk of how change in medication from an anti-TNF to a JAK kinase inhibitor can result in a whole host of things which you need to be aware of if these are not drugs you use routinely, really. So in inflammatory joint diseases as rheumatologist, I'm a pediatric rheumatologist, a slight distinction from Jim, who's an adult rheumatologist. You've already heard about the scleritis, episcleritis, and rarely uveitis, which you can see in rheumatoid. You've heard about the acute anti-uveitis and spondyloarthropathy. You've heard about what's less well appreciated, uveitis and psoriatic arthritis. And then, of course, within the world of pediatrics, really, bulk of the chronic anterior uveitis really is JIA associated. Even the ANA positive or negative chronic anterior uveitis without arthritis is really the same disease as JIA associated uveitis. So enough reasons for the rheumatologist and the ophthalmologist to work together. But probably where the rheumatologist can add a lot to the world of ocular inflammation, be they scleritis, episcleritis, or uveitis, is our understanding of the underlying immunology and the immune-mediated processes that happen either in rheumatoid angstpond or in psoriatic arthritis, or increasingly in the different subtypes of juvenile arthritis. And here I'm just giving you a paradigm of what happens in rheumatoid-associated ocular surface inflammation. And it's not that dissimilar to what happens in the synovium. You have a host of cytokines, all of which have now got blockers such as TNF, IL-6, IL-12/23, all of which are drugs I'll come back to, interleukin-17, which plays a pivotal role in angstpond. So really the immune processes that are mediating the inflammation, whether it's in scleritis, episcleritis, or in uveitis, are not dissimilar to that which mediates the inflammation in the synovium, really. But it's the psoriatic arthritis, again, I want to focus on. Everyone touches on rheumatoid, on ankylosing spondylitis and JIA. But really, there are 3 organs involved in psoriasis: the skin, the bowel, and the eyes. And everyone's aware of the joint and the psoriatic arthritis, the skin, the bowel disease, which is associated. But if you look here, the spondyloarthropathy that you can see with psoriasis might almost be, or the acute anti-uveitis and spondyloarthropathy, is probably an enthesis similar to the ciliary body being attached in the eye to the enthesis in the rest of the body, such as the Achilles tendon, and activation of the innate immune system and then the adaptive immune system. Some forms of spondyloarthropathy are probably more of an innate immune system drive, an autoinflammatory disease, similar to the systemic granulomatous disease or the autoinflammatory conditions that we see like BLAU. And I put this because gut dysbiosis and the microbiome as an increasing role, and you probably will hear about this more in the next decade to come, about the role of dysbiosis in uveitis and the role of the microbiome really. Previous speakers have touched on, and what I want to say to you is almost half of the patients with spondyloarthropathy over the course of their lifetime, and the longer you follow them up, will develop a form of acute anti-uveitis. Now, most of these acute anti-uveitis will settle with topical steroids, but occasionally they won't. And someone's already, Dr. Kalpana has already alluded to this, but I want to take a bit more time, how you as ophthalmologist might be the first presentation. So if you see a young adult between the ages of 20 to 40 with acute anti-uveitis, and you ask for a diagnosis of spondyloarthropathy, if they do not have it, then you ask for a history of back pain. But more often than not, given that this population of 20 to 40 is probably more sedentary, playing computer games, will have dismissed their back pain as something to do with either their occupation or their school or their university. So if they have back pain, which is a specific question you have to ask, it's worth checking the HLA-B27. If they do not have back pain and their B27 is a negative, it's fine. But if their B27 is positive, any adult with B27 positivity, it's best to refer to a rheumatologist. If they're B27 negative, it's worth asking or examining them for psoriasis. And again, if they have psoriatic skin lesions, even if B27 negative, it would be appropriate to refer to a rheumatologist. And the role of the rheumatologist in these uveitis patients will be in diagnosing their inflammatory psoriatic arthritis or their inflammatory spondyloarthropathy early so that appropriate immunomodulation can be referred to. So what are the red flags for a referral to a rheumatologist? I thought because you're a vast audience of uveitis experts and ophthalmologists. So if you're B27 positive, you have a very high chance, and that's you can see that the B27 positive newly diagnosed spondyloarthropathy is about 90%. Have recurrent uveitis, which is again a huge red flag, have suffer from back pain. So if you see acute anti-uveitis, if they're either B27 positive or recurrent attacks of acute anti-uveitis, excuse me, or acute anti-uveitis patients who have a history of back pain, do not forget to refer them to your rheumatologist. Now, where we might come in handy to you is in the systemic therapeutic options. And there are loads of trials such as MUST, which show that systemic immunomodulation is far better than local immunomodulation, such as injecting steroids or implants. And the therapeutic options are huge. You may use steroids, you may use synthetic disease-modifying agents such as methotrexate, cyclosporin, or mycophenolate mofetil, or increasingly biologics such as TNF inhibitors, and maybe in the future, small molecules such as JAK kinase inhibitors, and we'll touch on that. But where the ophthalmologist can help the rheumatologist and where the uveitis will be helpful can be seen in this example. Here's a 33-year-old female who presents with inflammatory back pain, which has been going on for several years. Now I'm going to give you the rheumatology way of the examination. A physical exam is unremarkable. A Bath ankylosing spondylitis disease activity index, which is a measure of how disabled or impaired she is from the spondyloarthropathy, is 4.4, B27 positive, elevated CRP. But most importantly, over the last year, she's had 3 episodes of acute anti-uveitis in the left eye, and she's currently only on naproxen. A plain X-ray of the pelvis demonstrates possible unilateral sacroiliitis. But increasingly, we do MRI, and we call this non-radiographic ankylosing spondylitis, which to me is a slight oxymoron, but for the ophthalmology community, do remember that when we say non-radiographic, we mean not on a plain X-ray, but seen on an MRI. And of course, MRI is what most of us resort to, and you can see bilateral bone marrow edema consistent with definite sacroiliitis. Now, the ophthalmology report describing recurrent acute anterior uveitis with increasing possibility of developing complications and a poor response to local therapy would twist or make the hand of the rheumatologist move towards systemic immunomodulation, such as anti-TNF or anti-IL-17 in this patient. So what can rheumatologists and ophthalmologists offer each other? I've been running a combined clinic with my ophthalmology colleagues for almost 2 decades now. It has enabled us to share the patient management, better understand inflammatory disease, both in the joint and in the eyes. And of course, we can share our knowledge of immunosuppressive therapy. We can, of course, learn from you. And Jim's given you a good example of when you should be worried about infection. You've had a good example from Dr. Kalpana about the ocular complications sometimes of systemic immunosuppressive therapy that the Rheumatologist Institute. But most importantly, in these 2 decades, we have been able to improve outcomes because we've had much better referral, earlier diagnosis, but most importantly, early initiation of treatment by working together and understanding each other's perspectives. From a rheumatology perspective, we find uveitis to be heterogeneous. Even though in trials you try and lump them together, we would never do a drug trial which includes a rheumatoid angstrom in a psoriatic patient. But somehow several of the uveitis trials seems to put birdshot and VKH and idiopathic panuveitis, which is why I speculate that many of the clinical trials of therapeutic agents have not worked as well. The pathophysiology of uveitis, at least from mouse models, which the first speaker touched on, is not dissimilar. It's poorly characterized, but we speculate it might be an environmental trigger and genetic risk factors, both of which have not been well identified. But the cytokines involved are agents which have a host of drugs, and I'll come back to. We now have a host of drugs which block 1223 pathway. We have monoclonal antibodies to IL-23. We have several agents which block IL-17. We have a couple of drugs which block IL-6, and we have gamma interferon blocking agents as well, certainly. So there is a lot that we can share. And of course, the drug which everyone's most familiar with and licensed is adalimumab, which you all know is an anti-TNF, really. When you're looking at managing anterior versus non-anterior, non-infectious uveitis, and everything I'm going to say is non-infectious, you're really looking at either topical therapies predominantly for anterior uveitis, with systemic therapy being needed only in selected cases, whereas mainly systemic therapies for non-anterior uveitis, be they intermediate, posterior, or pan-uveitis, with occasional intraocular therapy reserved for selected cases. And that's what really the MUST trials show us. If you look at the host of therapies we use, I've divided them into biologics and non-biologics. In the non-biologics, you have the anti-metabolites, azathioprine, mycophenolate, which methotrexate and mycophenolate are probably the most used. Methotrexate probably has a higher safety profile, less well tolerated by patients. Mycophenolate is probably extremely well tolerated and is probably the go-to drug in lots of settings. There are instances where you can use calcineurin inhibitors such as tacrolimus or cyclosporine. We rarely, in the era of biologics, use cyclophosphamide, chlorambucil. The mTOR inhibitors such as sirolimus may be reserved for very specific settings in highly refractory patients, or where the pathophysiology points towards the mTOR inhibitors being helpful. Where the world's moved on in the last decade is in the use of anti-TNFs. Really, adalimumab and infliximab are the go-to agents. Golimumab, which is a longer-acting adalimumab, really. And then the interleukin inhibitors, IL-1 inhibitors, such as anakinra, is very effective in certain monogenic diseases, such as neonatal onset multisystem inflammatory disease. And then IL-17, IL-12, 23, and IL-6 blockers, certainly. IL-6 blockade is incredibly helpful in macular edema. Personally, I don't think there's a role for rituximab or abatacept because even anecdotes are not that effective in these patients. But there are multiple challenges which we need to work together with you, our ophthalmology colleagues, that non-anterior, non-infectious uveitis can be vision threatening, as most of you know. And we need to work with you to ensure that topical treatments are ineffective and that we need to move to systemic therapies as soon as possible. But we need to avoid long-term chronic corticosteroid use and go to either synthetic disease-modifying agents or biological agents, really. There are there's a particular absence of universally accepted therapeutic guidelines, and maybe IUSG can work on this in the future to come through this. Jim and I were part of an initiative along with Andrew Dick called the Fundamentals of Care for Uveitis, which we published a few years ago in ophthalmology. And that was looking at multiple things, really. Area one was looking at the optimal timing for initiation of systemic therapies and then transitioning from a non-biologic to a biologic. But I'm going to touch on focus 3, which is how we work together across different disciplines, really. The methodology, which was these 3 areas were selected by the steering committee, which Jim and I were part of. And we had multiple questions which were ranked by people from all around the world. And we had almost more than 100 faculty members and went through the PRISMA protocol and then through a Delphi process and eventually came with 21 final evidence statements, which were published. But the most important is working together with the patient and across the disciplines of either internal medicine, rheumatology, with the ophthalmologist in making sure that when we initiate systemic immunosuppressive therapy for non-infectious uveitis, we work across disciplines in enabling the best care for the patient. And we need to have effective communication between internists, rheumatologists, and ophthalmologists, because we need to ensure that we do the right prescribing, right monitoring, and initiate the systemic therapy with appropriate safeguards in place, really. And this is crucial in ensuring good communication. All the more important because the therapeutic landscape is dramatically changing from just having drops and occasional subtenon and intravitreal injections and ocular implants to systemic steroids. These used to be the mainstay, but really systemic immunosuppressive therapy is starting to play a crucial role, and advent of biologics means the role of the rheumatologist is fast expanding, both in helping you in managing your patients and probably presenting you with a few challenges, which is because of the use of biologics, really. And there are multiple factors, and I know that this IUSG forum has folks from multiple countries, multiple continents, and the factors which influence the choice of treatment could be age, compliance, uveitis diagnosis, but could also be the physician's experience, published guidelines, the cost, which might vary in different ages, which are the non-patient factors and patient factors. The bit which I'm not going to touch on in great detail is the pre-therapeutic assessment before commencing immunosuppressive and biologic therapy. One of the previous speakers already alluded about the risk of TB in certain settings, the need to do either gamma interferon assays or MAN2 or PPD, purified protein testing, and monitor these patients regularly. You don't want to treat the systemic disease and then develop tuberculous uveitis, or treat the non-infectious uveitis and then get an infectious uveitis. But the future is fascinating. The future is full of small molecules. We have a host of JAK kinase inhibitors. Of course, you saw the bad side of tofacitinib in the thromboembolic manifestations that were shown, but that can be a good side as well in terms of small molecules can be cheaper than biologics because they are cheaper to make when they go off patent. And if you can do the appropriate trials, then maybe they will have an important role to play. Small molecules are further upstream, so they can affect multiple pathways which are mediated by cytokines such as hematopoiesis, growth, Th17 differentiation. They have antiviral effects and activate NK cells, which can be very crucial in the anti-inflammatory cascade. And of course, I touched on the fact that these days anti-TNF is not the targeted therapy for angst, but instead it's drugs which target IL-17 pathways such as secukinumab, ixekizumab. We have bimekizumab, which targets both arms of IL-17, IL-17A and F. And then there are molecules which target IL-23. Giselkumab and risankizumab have really revolutionized the management of psoriatic arthritis and psoriasis. These are incredibly effective drugs in the management of psoriasis. Ustekinumab is very effective. It's an IL-12/23 blocker in the management of inflammatory bowel disease. And I hope that there are clinical trials in uveitis, and I'm sure the next speaker will touch on that. We are running a couple of trials, and it's a pitch. Nisha and I are running a trial of once you control JIA-associated uveitis with anti-TNF, when do you stop? After 12 months, after 18 months, after 24 months? So this is a UK-US study. Hopefully in a year, we'll have the results. I'm also running a trial of baricitinib with Lilly in the management of JIA-associated uveitis. And what we're doing is using Bayesian analysis and doing a small head-to-head with adalimumab, which is a standard of care. So we'll get data both on biologic naive and biologic refractory patients. I'm also about to start a study in the next month of secukinumab in pediatric uveitis, again, looking at both refractory patients, refractory to adalimumab, and then doing a small head-to-head of secukinumab versus adalimumab. Probably the next speaker will touch on many of these in greater detail. Happy to take any questions on the chat. Thank you very much again to Dr. Vaishali and all of those for inviting me.
Thank you very much. Thank you, Ram. And with this, we move on to our last speaker, Dennis Wakefield, who's staying away. Thank you, Dennis, all the way from Australia. So he's going to discuss new and emerging therapies for severe non-infectious uveitis, and this will be followed by discussion and controversies. Over to you, Dennis.
Thank you, Vaishali. I'd also like to thank the last speaker for giving an introduction to what I'd like to talk about tonight, and that is new and emerging therapies for patients with severe non-infectious uveitis, which is mainly posterior uveitis, pan-uveitis, and intermediate uveitis. I'll initially review, if I can get my slides, sorry. I'll initially review our current status in terms of what we're doing in the treatment of patients with severe non-infectious uveitis before moving on to some of the newer concepts of therapy that we'll be looking at in the near future, some of which Professor Ramanand's already mentioned, and I think it's going to be quite an exciting next few years as we pass through the biologics revolution into more small molecule treatments and other ways of treating uveitis. It's probably reasonable to start at the most important part of this talk, which is what are our aims of treatment in patients with non-infectious uveitis. Well, the first aim, of course, is to preserve vision and to relieve the patient's symptoms. We also need to control associated systemic disease, and that has been addressed by the previous speakers. We want to prevent the complications that emerge from uveitis, but also prevent complications of treatment. And again, this comes back to having a good arsenal of treatments available to us that are both effective and lack severe complications. There have been a number of changes in the paradigms around which we treat patients with posterior uveitis in the last few years, especially in the era of biologics. One of it has already been alluded to, and that's careful pre-treatment evaluation, looking for risk factors, and the use of biologicals that introduce a whole new gamut of risk factors that we previously weren't concerned with, such as demyelinating disease or paradoxical induction of other autoimmune diseases in patients who are commenced on biologics. We also want to minimize the use of systemic steroids in terms of dose and duration. And most of the recent studies indicate that it's probably reasonable to try to achieve a low dose of prednisone down to 5 milligrams within the first 3 months of induction therapy in patients with severe uveitis. There's this increasing shift towards early treatment with immunosuppressive drugs and biologicals, and I'll come back and talk about that. About 10 years ago, when I gave a similar talk, there was a study indicating that most people treating uveitis did not adhere to treatment guidelines, and there are good guidelines that have been put forward by both the IUSG and the American College of Ophthalmologists that really should be adhered to because they're based on a large amount of experience in the treatment of these diseases. My previous previous speakers and my colleagues have also emphasized the importance of having a team approach to therapy in terms of management of systemic disease and also the management of therapy for patients with idiopathic and non-infectious uveitis. There's a trend towards avoiding alkylating agents, and we have not used alkylating agents in the management of uveitis for some years now. I'm pleased that we have finally got to the point where in uveitis studies we can do clinical trials using well-defined criteria such as the SUN criteria. that will give us meaningful results and comparative studies between different treatment regimens in the management of patients with posterior uveitis. In the future, we'll be looking towards precision medicine and emerging new therapies that will help us better manage the patients with severe posterior uveitis. My colleagues have already alluded to some of the newer emerging targets for therapy in uveitis. We've lived through an era where cytokines have been the major target, particularly anti-TNF therapy, but also other cytokines such as IL-1, IL-6, IL-17 and 23, which have already been mentioned by previous speakers. JAK kinase inhibitors also are now more widely being used. And again, there are trials in patients, which I'll come back to and discuss in a minute. Phosphoesterase inhibitors have been used in patients already in small, uncontrolled trials and shown to have some efficacy, as well as other DHA ODH inhibitors such as KO 100, which has recently been shown in a phase 1 trial to be effective after injection into the vitreous. And of course, although there's been a lot of work done on the human microbiome, and on experimental animals, we still haven't got any clear indication as how we can manipulate the biome to actually influence disease manifestations. Gene therapy, gene silencing and the use of plasmid vectors is another area of intense research. And there are now a large number of novel delivery systems that I'll mention shortly. Our approach to the management of uveitis at the moment follows the same trend as it did about 5 years ago, in which we tend to divide patients up into those with systemic disease, in which the management plan is usually to treat the systemic disease. If this responds, then they go into a maintenance therapy, or we'll come back to how we treat relapse in a minute. If there's continuing inflammation or if there's no systemic disease, we usually induce remission with corticosteroids. And as I said, the aim should be to minimize the dose and duration of steroid therapy. And we're talking now about systemic steroid therapy. We tend to introduce steroid-sparing agents such as methotrexate, azathioprine, mycophenolate, or cyclosporin early in the management of these patients' conditions, particularly in people who have severe bilateral uveitis, which is either poorly controlled by steroids or requires continuing high doses. Not everyone responds to these DMARDs, and some people who fail such treatment either can be managed by changing to a different DMARD, for example, from methotrexate to mycophenolate or azathioprine. We tend to use less cyclosporin these days, mainly because the side effect profile is not really well liked by patients. They don't like the hirsutism and the tremor, and we don't like the fact they become hypertensive and get renal impairment. And our management strategy, therefore, is to introduce the use of biologicals, particularly anti-TNF therapy, in patients who aren't responding to this DMARD type of therapy. We've now had over a decade of experience with the use of TNF inhibitors in the management of patients with uveitis, and we know that they are quite effective in non-infectious uveitis, in B27-related disease, in juvenile arthritis, sarcoid, Behçet's retinopathy. There's compelling evidence for its efficacy in Behçet's disease, with good data now showing that there's about an 80% early response rate to most TNF inhibitors. But when I say most, I should limit that because our experience is mainly limited to adalimumab and infliximab. Unfortunately, these drugs don't induce long-term remission. And in fact, there's good data now going out for over 5 years in patients on continuing TNF inhibitor therapy, only to find that every time you try to stop the therapy, the disease relapses. There's also an increasing range of biological agents and now biosimilars to help us in the management of patients requiring such therapy. There's no good evidence at the moment as how long we should continue this therapy. And again, this is a major problem because these drugs induce remission, but they don't cure the disease. The good thing about the biologics, particularly the TNF inhibitors such as adalimumab, is they have quite an acceptable side effect profile. It can be used in pregnancy, as can Imuran, although methotrexate and mycophenolate are contraindicated. And in our hands, they have a relatively low failure rate, and I'll come back and discuss that shortly. The previous speaker mentioned the importance of pre-treatment consideration before we start people on biological agents, and this includes ensuring that there's no active infection in the form of TB or one of the hepatitis infections or HIV, but also things such as heart failure and demyelinating diseases. Patients with intermediate uveitis routinely have an MRI of their brain to ensure there's no evidence of an underlying demyelinating disease before commencing TNF inhibitory therapy. Similarly, we should be very careful about further immunosuppressing patients who have an underlying malignancy and be cognizant of other immunosuppressive drugs that are going to be used in conjunction with the biologics. Pregnancy is a problem, and as is lactation in terms of immunosuppression. And again, the good news there, I suppose, is that adalimumab is acceptable, and we've now used it in quite a number of patients during their pregnancy. One of the interesting aspects of biological therapy is this paradoxical reaction that some people get, in which after commencing a TNF inhibitor, they develop another autoimmune disease which may have been present, such as inflammatory bowel disease, when they're commenced on TNF inhibitors. And as has already been mentioned, sometimes these patients will also develop uveitis as a complication of TNF therapy. If we look at the different diseases at the top of the page, into AU, juvenile arthritis, non-infectious uveitis, Behçet syndrome, VKH, birdshot retinopathy, and sarcoid. In terms of the different cytokine inhibitors that are available, I've tried to summarize the different drugs that have been used in these conditions in terms of whether they've been effective or not. And the TNF inhibitors overall have been effective in most of these forms of uveitis, although, as the previous speaker mentioned, these trials have not been well conducted in the sense that often only small numbers of patients have been looked at. There's no comparison to placebo in a lot of the trials. They're often retrospective. And again, it's hard to get a good handle on just how effective these forms of therapy are. But one thing is clear from our experience, and that is that adalimumab and infliximab in particular seem to be effective in helping control the inflammatory response in most forms of non-infectious uveitis. There's less experience with the other anti-cytokine therapies. IL-6, for example, has shown some efficacy in anterior uveitis, both B27 related and non-B27 related, as well as JIA, but has not been as effective, for example, in the non-infectious uveitis populations. IL-1 is in the form of anakinra anyway, has been used in patients with JIA and birdshot retinopathy with some reports of its efficacy. Similarly with IL-2 receptors, again, I have had no experience with the use of dacilizumab in this sort of context, but it has been reported to have some efficacy in non-infectious uveitis patients. IL-17, which has been of considerable interest in recent times in the rheumatology literature, has been reported to be helpful in patients with non-infectious uveitis, although the data on birdshot retinopathy from Andrew Dick and his colleagues indicates that it probably is not effective in patients with birdshot with Behçet syndrome, I should say, or birdshot retinopathy. again, one of the things that's of interest at the moment is the use of IL-12/23, P40 biological therapy, and there are trials going on at the moment in the use of this in both anterior uveitis and in Behçet syndrome and birdshot retinopathy. And we look forward to seeing the results of these studies. Other biological agents that have been used include rituximab, which has been used in most forms of uveitis, again, in small studies, again, often retrospective, with no comparison, no control group, which is understandable in the case of the treatment of uveitis. And again, overall, they show that this medication, it has some effect. We've had very limited experience with this in patients with non-infectious uveitis, and we've mainly used it in patients with other forms of inflammatory eye disease, such as the bullous diseases of the conjunctiva. Similarly with betasept, an interesting molecule to attack. Again, it's been used in JI and non-infectious uveitis with some reports of efficacy. A more interesting therapy, however, is the use of interferon, such as interferon 2 alpha, which has been shown to be effective in clinical trials in patients with non-infectious uveitis and Behçet syndrome and BKH in particular. It seems to be quite effective in patients with macular edema, helping resolve macular edema in such cases. As has already been mentioned, JAK kinase inhibitors in the form of tofasitamab is being trialed in patients with JI and in non-infectious uveitis. And early reports of small numbers of cases indicate that this may be effective. Intravenous immunoglobulin has been used in the treatment of a number of different types of uveitic syndrome. And again, although there are reports of some efficacy, this is a very costly form of therapy, and most blood banks won't release this drug for this under most circumstances. The phosphodiesterase inhibitor Premolist has also been reported to be of some help in some of the manifestations of Behçet syndrome without good controlled trials showing its efficacy. One of the issues that we do have in the management of patients on biological therapy is that not everyone responds to this form of therapy. And then what do we do after they've failed the TNF therapy? And this can be divided into a number of different effects. Primary lack of efficacy occurs, and with treatment failure, in the Visual 3 study, some 25% of people in the study fail the therapy at the 18-month period. That there can maybe secondary loss of efficacy after initial response, and the secondary failure in the Visual 3 occurred in about 13% of the patients, or partial response, which occurred in about 10% of the people. Adverse events are actually quite uncommon compared to other drugs in the treatment of patients with uveitis, and 2 to 3% of patients have an adverse effect necessitating stopping the drug. And in our experience, this is usually very well tolerated and with few side effects, and most people tolerated, with over half patients still being able to tolerate it without any problems at 5 years. What do you do when patients fail anti-TNF therapy? Well, the French have reported that their way of approaching it is if you find that there's a decrease in the TNF level or the person has anti-TNF antibodies, then you can either add another immunosuppressive agent or switch to a different TNF, or escalate the dose escalate the efficacy by increasing the dose or decreasing the interval between dosage. We don't usually do that. We usually find if a person hasn't responded to the TNF therapy, then we would either swap their underlying immunosuppressive medications, for example, from methotrexate to mycophenolate, Imuran, or cyclosporin, and then introduce another biological and try interferon or IL-6 in this sort of circumstances. There are studies showing that the people that develop anti-TNF antibodies, only about half of them actually are having any effect, and they're usually tolerated by the patient without decreasing the efficacy of the TNF therapy. One of the problems that we have with immunosuppression in patients with uveitis is cost and access to the major different therapies. I appreciate that Dr. Agarwal reported this study 2 years ago in comparing the price in India of the different drugs. Unfortunately, this is almost universal, that the same cost differential occurs in our country, in Australia, and I'm sure in Europe and the United States, as well as most of the countries in Asia and Africa as well. That the biologicals are very expensive, as you can see from the cost of adalimumab and infliximab at the bottom, compared, for example, to methotrexate and azathioprine, which are relatively cheap, as is cyclophosphamide, which is one of the reasons that it's still widely used in some precincts. We're fortunate that we can get adalimumab and the Imuran, methotrexate and mycophenolate on our health scheme, but the other new biologicals and that are still expensive and really are inaccessible. And the problem with the infliximab, of course, is that it's intravenous therapy, and that means the person has to come into the clinic and have the intravenous therapy, which again is costly and in terms of healthcare as well as the cost of the drug. So what about the future? One of the major interests at the moment in rheumatology and in autoimmune diseases in general is the promise of precision medicine in the treatment of autoimmune diseases such as uveitis. We share a lot in common with our rheumatology colleagues in terms of the disease, in terms of there's a lot of heterogeneity in clinical presentation, disease course, and treatment response in patients with autoimmune diseases and in uveitis. And it would be nice if we could have tailored treatment to the underlying pathological or pathogenic mechanisms that exist in these conditions. And this can be done by profiling the mediators that are causing the inflammation at different times and stages in the disease. And the revolution that's occurring in our understandings of molecular biology, genetics, and all the omics at the moment is going to give us a good handle on how we actually can dissect out the major mediators and then target them specifically. And this has been driven by innovations in molecular biology, genetics, and the omics technology. Professor Ono presented this rather complicated slide recently in a paper in Frontiers, in which he looked at the genetic factors implicated in a number of diseases, including Behçet syndrome, anterior uveitis, Voigt-Korenar-Harada syndrome, and sarcoid. And if you look at this carefully, you will see that he's highlighted in different colors the different diseases. And if we just concentrate for a moment on anterior uveitis and Behçet syndrome, which is in the pink and the yellow, you can see that a number of genes are implicated in this, the pathogenesis of these diseases. And these not only include the MH class 1 antigens, the ERAP proteins within the cell that are responsible for pruning antigens and having them presented via the class 1 MHC to respective immune cells, but also other factors including IL-1, TNF, IRF, and again, a number of others. But one of the ones I'd like to highlight is the IL-23 receptor, which has been mentioned previously. And it's important to realize that this is a genetic marker, not just for anterior uveitis and Behçet's, but also for Voigt-Korenar-Harada syndrome and for sarcoid. And this may have great promise, in fact, as another form of therapy in the management of patients with uveitis. But it also, this slide, even though it's complicated, points out the fact that there are potentially a large number of targets for therapy in terms of blocking inflammatory mediators in the treatment of uveitis. Let me just finish by saying a little bit about intravitreally administered compounds and their clinical use in the treatment of posterior uveitis. most of us are familiar with the steroid implants that are now available for slow release of a steroid, and we use these quite commonly to help control patients with uveitis, especially if they've failed steroids, systemic steroids, and then have got an immunosuppressive and have relapsed in that. And while we're waiting to get control with a biological, we'll often put in a Retisert or an Ocidex implant. Other things that have been tried include sirolimus, which has been shown to be effective as an intravitreal injection. Recently, the dihydrofolate reductase inhibitors, which affect both the T and B cells, have been shown to be effective, as is methotrexate, TNF inhibitors, and the VEGF inhibitors in intravitreal injections, although they're not as effective as systemic therapy. We can look forward to a burgeoning number of drug delivery platforms that are going to help us in the future in terms of systemic therapies with adoptive transfer, and the concept that's been well looked at in terms of experimental uveitis is T regulation expansion and nanoparticles as a way of administering drugs to the target organs in concentrated forms, topical therapy with nanoparticles and drug-eluting contact lenses, or subconjunctival nanoparticles, subarachnoid plasmids, which can contain genes that will involve inhibitory molecules that will decrease the inflammatory response, as intravitreal, as well as intravitreal implants and injections of T regulator cells or anti-TNF agents, or surgically implanted deliveries, devices, or plasmid vectors. So what I've tried to do in this brief overview is basically give you a concept of how we're managing uveitis at the moment in the era of biologicals, and how I feel that we'll be transiting in the future. We'll be introducing new forms of therapy in the forms of small molecules, new delivery systems for these molecules, and also using precision medicine to actually target different molecules within the inflammatory cascade to give us better control of patients with uveitis. Thank you.
Thank you, Dennis, and welcome, Jim. And with this, we start our session on the controversies related to the current topic. Now, the first topic, Claudia beautifully mentioned about epigenetics, environment, microbiome. I would start with Jim. How much attention you pay to modifying these factors in your rheumatology with or without uveitis practice? Is it just the talk, or does it have a transitional value yet?
So, you know, I've been doing this for almost 4 decades, and my attitude has changed. So I used to hear regularly from patients, I changed my diet, I did this, I did that, I'm miraculously better, and I thought it was coincidence or placebo effect. And now I tend to believe that it's the microbiome. But the microbiome is clearly complicated, and ways that you might be able to change it personally might not extrapolate to another individual. So I tell patients diet, exercise, stress, all those things are unbelievably important, but you have to find your own path. And whatever you do, don't do it to an extreme. So yes, you may find that you can change your diet and it makes a difference. But I don't know exactly what is the optimal diet. All I know is that it's very important and we're learning.
You know, Jim, if you go to the old Indian Ayurveda, all the problems originate from the gut, and there is a diet for each problem, which, as you said, like we never believed till we started hearing about the microbiome, and maybe it has a role, we do not know. So Ram,
Exactly.
in your practice, do you anything other than what Jim said?
No, we all know that the microbiome is important, but we don't know which species, which bacteria, how do you influence it? People talk about probiotics. We are convinced it matters. What we are not sure is how do you influence it? And even the probiotics that are commercially available don't make much sense. In fact, if I can go a bit further, if you go back in ancient Indian folklore, every time a bride comes into the house, they'll bring their own yogurt mix, if you like. And that was meant to have a heterogeneity. But we have no evidence that a commercially available expensive yogurt is any better than a natural live yogurt for that matter, because the exact species that the microbiome needs to be constituent of is not known. So in the light of that, all you can do is the same advice Jim gives, try and be as healthy, but without knowing what that means exactly.
So we do advise some form of counseling and a healthy lifestyle. So Kalpana, you brought a very interesting issue and you showed a beautiful case where tofetinib induced like CRVO kind of a picture. Now, what is your experience of using JAK inhibitors? Because this is still a topic not everybody is comfortable with. And my question to Kalpana and Dennis and all of you is, we talk about JAK inhibitors causing uveitis. We talk about JAK inhibitors treating uveitis. So when a patient on JAK inhibitors gets the worsening, how do you know, is it the phenotype of the original disease that is changing, or is it the side effect of the drug that you are using?
I think that's a very difficult question, Vishali, because probably the only way you'll find out is to stop the drug, see if the disease improves, then re-challenge them again. And we're all reluctant to do that in a way with uveitis. But yes, again, the same thing happens with etanercept and things like that, where the TNF inhibitors also have been reported to induce uveitis as well. So we don't know whether the disease is getting worse because they've got antibodies to the TNF and it's not working, or whether or not this actually is a paradoxical reaction, as they call it, to the TNF inhibitors.
And I think there is the question from Leonardo Campos for you, Dennis, which is related, which says that how often would you measure TNF levels in patients with uveitis and failure on TNF therapy? And what would be the threshold for you? Do you measure?
No, we usually don't measure it, in fact. And the reason we don't is because when we've done it, it hasn't been very reliable in guiding our therapy. As I said, half of the people that have the antibodies have no problems with the TNF at all. It's working fine. So we don't do it. If they fail, if they're not getting better on TNF, and we use adalimumab almost exclusively now, then our first approach would be to go from 2 weekly injections to weekly injections. And then if that works, then we would leave them on that if we can get the supply from our health providers or from the drug company. And if they still don't get better, then we'd switch them to a different biological. Well, it used to be interferon, but now we're having trouble getting interferon because it's no longer used for hepatitis and MS. So we would then think of using IL-6 inhibitors.
And Kalpana, there is a question for you by Marianne. Is soluble interleukin-2 receptor used uveitis as a biomarker for sarcoidosis, or do you need systemic disease to use this biomarker? IL-2 receptor soluble.
I think IVO's classification has added IL-2. But unfortunately, in our part of the world, we don't have any means of IL-2. So we still rely on radiological evidence and biopsies.
And in other parts of the world, Jim, do you rely on soluble IL-2 receptors?
No, I find ACE, lysozyme soluble IL-2 to be too non-specific. So I agree that radiologic imaging is, a CAT scan of the lungs is usually our most sensitive and specific test, and biopsy if tissue is easily available, but usually we don't bother.
And coming to your talk, Jim, there is a lovely question for you from Sagar Agarwal. He's written, Dr. James, sir, how do you define retinal vasculitis?
That's a great question. And that's actually, part of the issue that I hoped I elucidated a little bit, is that retinal vasculitis to an ophthalmologist has a very different implication from retinal vasculitis to a rheumatologist. But I'd say retinal vasculitis is evidence of retinal vascular malfunction in the form of leakage, occlusion, exudate, or all of the hemorrhage, or all of the above.
And you brought a very relevant question of peripheral vascular leak. Now, this peripheral vascular leak, more and more people are reporting in JIA, and something we traditionally thought were anterior uveitis. But now that imaging we are doing, we are, finding that. So would you take that seriously and treat? That is my first part of the question, and I would open it to all of you.
Right. Maybe 40 years ago, we started doing echocardiograms, 45 years ago, and all of a sudden we found this disease called mitral valve prolapse that we'd never found before. And then we found that so many people had mitral valve prolapse, and it's taken a long time to sort out what is the implication of an abnormal echocardiogram with mitral valve prolapse. We're in a very similar situation now. Our technology is so wonderful. Our imaging is so wonderful, but we're also beginning to find things that we don't quite know how to handle. The same happened with MRIs of the brain, where we find so-called UBOs, unidentified bright objects. So I don't treat the angiogram per se. I treat the symptoms, and I offer the patient options. And that's a delicate balance of trying to not overwhelm the patient and think that I'm incompetent or indecisive. At the same time, recognizing that different people have different approaches. And, if your life is all about going hunting and you use your right eye to shoot and it's slightly abnormal, you may want to take extremes. And on the other hand, if your life is all about meditating and vision's important, but not, you could tolerate a little bit of visual loss, you probably don't want any therapy at all. So it's a very individualized approach, I hope.
And Dennis, suppose you are following a patient of retinal vasculitis with whatever therapy you are giving. Now you want to taper off the therapy, and you are monitoring him on fluorescein. So what would be your end point on fluorescein? Patient is asymptomatic and no new complaints. So what is your end point of fluorescein leak to stop immunosuppressive therapy?
Well, I'm not an ophthalmologist, as you know, Vishali. So I would actually talk to my ophthalmology colleagues and ask them how to interpret that for me. Having the embarrassing situation that I'm often shown fluorescein angiograms and then say, well, you tell me what's going on. I think in terms of therapy, but again, you want to get to the stage where you haven't got leaking vessels. But as Jim says, it's really a matter of what the vision is anyway, and what the level of activity is. And so just looking at a fluorescein and saying there's leak is not enough. It's what else is going on. What I also, it gives me a chance to say something that I should have mentioned in my talk, and that is withdrawal of therapy is a real issue in uveitis management, because most of the time what we would do is try to get people off steroids as a first priority. And then our second priority would then be to get them off one of the immunosuppressive drugs. And then our last option is usually is to try and get them off the biologics. We hardly ever do that, unfortunately. I mean, one of the problems with the way at the moment, there's this huge concentration on blocking inflammation. And in a way, we've almost lost a vision for, can we cure these diseases? I mean, well, the quote I think is, the mission is remission. Well, I don't think so. I think the quote should be, the lure is cure. That what we want to do is go to the point where we're curing these conditions. And there's a recent study which gave me some heart that this may be possible with a model of autoimmune skin disease, where they actually identify the cells that were producing the antibodies against the intracellular cement substances that was causing the disease, eliminated those cells and cured the disease. Now, that was in an animal, but I mean, we're animals too. We just have to get to the stage where we can identify these rogue clones, as my colleagues call them, that are causing the disease and perpetuating it, and hopefully get rid of the rogue clones that are actually perpetuating the disease. Because at the moment, I think we're on a track of continuously supporting the pharmaceutical industries for creating drugs that do nothing but basically keep the disease in remission.
Thank you. Kalpana, what would be your threshold on fluorescein?
If I do watch them, I observe them for some time, and then if it's not increasing, or this is a problem which we generally see with intermediate uveitis, especially the children and idiopathic group. And I have watched, because sometimes it becomes costly for the patient, because in India it's dictated by finances as well. So in those cases, we just watch them, and if it's not changing too much, I do observe rather than, yeah. And I also look at the OCT and the macular thickening actually in these patients. And if it's increasing, then probably I would treat. If it is stable, then I would just watch along with the vision.
Jim, there are two questions for you. And I think you made a point which Stephen Thural wants to know. To make the diagnosis of retinal vasculitis, wouldn't you need other signs of inflammation like vitreal infiltrates, retinitis? And Mamta is asking that, like, what investigations would you advise for patients with retinal vasculitis when we know that there are no systemic associations? Should you investigate?
So I certainly make a diagnosis occasionally of retinal vasculitis without retinal infiltrates. There are subsets of retinal vasculitis, and if someone has intraretinal hemorrhage or perivascular exudates or leakage on a fluorescein, that's a vasculitis, whether or not there are infiltrates. But the need to treat may be different depending on where that vessel is and how symptomatic the patient is. I think we need to do a better job subclassifying retinal vasculitis and getting our database together. And I think there was a second part that I've ignored, Vishali, and you'll have to remind me what
The second part was that if there are no systemic associations, would you investigate?
Oh, so, the most important thing is to obviously take a very thorough history. But it is rare for retinal vasculitis to be associated with a systemic vasculitis, with the possible exception of Behçet's disease. And then my viewpoint is jaded because in Portland, Oregon, we see Behçet's disease, but not nearly as much as, say, in Japan or Turkey or even in India. So I, for example, would not order an anti-neutrophil cytoplasmic antibody test if someone had no symptoms of sinusitis or hearing loss or pulmonary symptoms. It wouldn't change my therapeutic approach. Plus, if you have so-called limited ANCA-associated vasculitis, the sensitivity of the ANCA is very poor. I wouldn't have an objection to doing a sed rate. I think occasionally we do a stool calprotectin because patients with inflammatory bowel disease like Crohn's can occasionally have a vasculitis. But in general, I don't do a lot of systemic workup unless the history has revealed something. I do check for sarcoid and for syphilis. And in certain parts of the world, I think it would be reasonable to check for tuberculosis.
Ram, you have been managing a uveitis clinic for 20 years now. So now we have, such a huge choices, anti-TNF, then rituximab, then tocilizumab, and so on and so forth. How do you decide which one to start in a particular patient? Do you have any preferences? Or do you have a fixed protocol? And would it be different for pediatric versus adult patients?
I'll try and address all of those, but before I do, I'll also touch on the fluorescent angiogram. We try and avoid doing it in our pediatric patients because, as Jim said, it's a bit like MRI. The more you MRI, the more you find changes in healthy people. So we stick with OCTs and rarely resort to fluorescent angiograms, which means we wouldn't have to necessarily worry about what you do if you did it. In terms of management of uveitis, at least in children, we try and encourage work with our local ophthalmology colleagues. And this is the point that Dennis makes, that there's a window of opportunity in inflammatory arthritis or most autoimmune diseases. And if you intervene with appropriate systemic immunosuppressive therapy early, there is a potential you might switch the disease off. There are one or two examples, certainly in autoinflammatory diseases. Whereas if you intervene late, then you're going to be on lifelong immunosuppression. So our first step is to persuade the colleagues we work with not to stay on drops forever and initiate. Our first choice synthetic DMARD is methotrexate. And if they are refractory to methotrexate, and we define anyone needing 2 drops or more for a couple of months as needing methotrexate, and anyone needing more than 2 drops on methotrexate after 3 months, we would consider adalimumab. Adalimumab biosimilar, because it's cheap, our government prefers us to use that as our first choice, and we do that. If they are refractory or to adalimumab, we will these days check the drug levels and antibodies, but only in those refractory. There's no point checking in those who are doing well. And if the drug levels are appropriate and the neutralizing antibodies, so there are 2 types of adalimumab antibodies, neutralizing and non-neutralizing. So you need to make sure your lab's checking neutralizing antibodies. If the neutralizing antibodies are high, the drug level is low, our government will not let us use weekly adalimumab, so we will consider switching. In those who are on monotherapy with adalimumab, who have high neutralizing antibodies, we will suggest that they take their methotrexate or mycophenolate regularly because that has a role in reducing the anti-drug antibodies. And then our next step is to go to tocilizumab because we have done a trial showing it does work in about half of the patients. Access is a problem. If they've got macular edema, tocilizumab is a particularly good agent. After that, really, you're in no man's land. We have a bunch of patients where we've switched adalimumab to infliximab and it works really well. But the disadvantage of infliximab is it's intravenous, or the formulation we use in the refractory patients is intravenous. And that's probably why even in the data that Dennis alluded to, the secukinumab worked in phase 2 in Andrew Dick's trial, but didn't work in phase 3. One of the multiple differences was phase 2 was intravenous secukinumab, phase 3 was subcutaneous secukinumab. So maybe uveitis patients need higher levels of drug. So after adalimumab, it's tocilizumab and then infliximab. JAK kinase inhibitors, we have to wait and see. There's enough putative reasons immunologically that they should work, but time will tell whether they do. And certainly IL-17 inhibitors are the future, along with IL-12/23. The problem is really one that you need to work hard with industry. Most of the trials I've done are investigator-initiated trials, is they're not interested in doing trials in uveitis because they don't find it commercially attractive because the population isn't large enough, which means the therapeutic pool of agents available is pretty limited.
Claudia, are you there? Can you switch on the camera, please? Yeah, can you unmute yourself? You have this huge registry, IDA registry about genetics, and you are looking at autoinflammatory diseases and uveitis, and you are, of course, going to lead the IUSG project. Where do you think the genetics playing a role for uveitis in future?
I think study monogenic autoinflammatory diseases for sure will tell us a lot about how certain genes interfere with the development of uveitis. And I think this should be one of the main reasons to pay attention to these monogenic autoinflammatory diseases.
And my question regarding that is, do you see, all of you, bioinformatics playing a role about choosing the therapy? Like Ram says, there are different choices and you follow one. Are we going to reach a stage where bioinformatics shall guide us as to what should be the ideal therapy for this particular patient?
If I can go first, Vishali. So that's exactly what we're trying to do. So we've got a large grant funded by the UK government. We've biobanked samples from our anti-TNF and our anti-IL-6 trials. Jim knows a bit about it because he sits in our monitoring committee. But what we're hoping to do is look at who responds to TNF, who doesn't, who responds to IL-6, who doesn't. And we're going to do that to our JAK trials as well as our IL-17 trials. And hopefully, there will be a biomarker that will predict. But even in the world of rheumatology, where this has been going on for a long time, it's proved pretty elusive. And that's, while it's exciting and we've been funded to do this precision medicine for right drug for right patient at right time, it's proving hard with all of the omics. It would be nice to get sample from the eye, because I think the peripheral blood samples are deeply flawed, but sample from the eye is much harder.
And there is one last question, and then we have to wind up. This is from Elizabeth, who says, for pediatric refractory uveitis that's not responsive to methotrexate, is it reasonable to skip anti-TNF and go straight to anti-IL-6? Anyone who has an experience, would you straight away jump to anti-IL-6?
Ram is the expert in the world.
You would? I would not.
No, Ram is the expert. I would defer to him.
I wouldn't. I think IL-6's efficacy, we haven't done biologic naive use of IL-6, but I would use our anti-TNF first. IL-6 first, maybe in those with macular edema.
And are any one of you, Kalpana, especially you, seeing HLA-B27 causing occlusive retinal vasculitis? Because Sonia says she's seeing.
Actually, we have about 500 patients now, and I've not seen, we were just looking up, and I've not had one case of occlusive except for this lady, which I presented. And that was so characteristic. She just had the history. She said after using the drug, she developed all the issues and it settled down. After that, we've not had any other issue. So occlusive, I don't think I've seen. We've had a group of patients who are ANA positive, and post-adalimumab, they've developed issues, post-vaccinations and all that. So it was not exactly occlusive vasculitis, it was more like a vein occlusion kind of issues we have seen. And I was told by my rheumatologist that it could be drug-induced lupus in these patients. So that was, a very small subset of patients which we had.
Right. We do have another webinar on these drug-induced things, so probably that is. With this,
I had a question, if I could ask Dr. Vishali to Dr. Ramanan. And see, in India, we're using a lot of patients on JAK kinase inhibitors because of the cost. And especially in the pediatric group, we've seen a good response in GIA, especially the ones with the granulomatous inflammation, like medium-sized KPs and even sarcoids, who are resistant to infliximab and adalimumab. I mean, I would just, because for us, it works very well in terms of the cost. So I would like to know your experience in pediatric uveitis in this particular group.
We use JAK inhibitors only in trials. I'm a bit worried about, of course, I know tofacitinib in India is extremely cheap, and post-COVID, baricitinib is also fairly liberally available, even though it's restricted for COVID. People I'd be a bit cautious because they are much more pleiotropic in their cytokine blockade, and the safety is an issue. The case you highlighted demonstrates one of the big issues. FDA and EMA have issued an alert for tofacitinib and baricitinib because there's a higher incidence of thromboembolic complications and major adverse cardiac events in large trials, which recruited to tofacitinib twice a day at 5 milligrams, tofacitinib 10 milligrams twice a day, and adalimumab. So certainly, anti-TNF would be my first choice, but of course, as you say, the cost considerations. And that's the major attraction. If we can show in well-designed trials that JAK inhibitors are effective and safe, then they have the potential of being as cheap as methotrexate or even as cheap as paracetamol, because they're small molecules. They can be made very easily.
But we do have randomized controlled data on a JAK inhibitor, namely filgotinib, right? That was presented at ARVO. It's a Gilead drug. And I should disclose that I've consulted for Gilead, but because of COVID, because of the success of adalimumab, this trial only recruited about 30% of individuals. It was designed to be very similar to the Visual 1 trial that, of course, AbbVie did that was so successful. And even with a 30% recruitment rate, filgotinib was clearly extremely efficacious for uveitis. But we do worry about thrombosis. We worry about hematologic side effects, even if they're, quote, very specific for JAK1. But the JAK inhibitors are also in evolution. So we're getting TYK2 inhibitors and TYK and SYK inhibitors. And I do think there's huge potential for JAK inhibitors, but we're dipping our toes in the ocean cautiously so far.
Thank you. With this, I would like to thank all of you, all the panelists in different time zones, so early for Jim and so late for Dennis. And thank you, Claudia, Ram, and Kalpana for joining us. And thank you, everyone. As usual, please fill in your CME credit forms. Give us the evaluation. You will receive an email and we'll be happy to issue the certificate. And we see you on 5th of November with the next topic is syphilis. Thank you very much, everyone. Thank you.
Thank you for including us.
Thank you.
Yeah. Bye-bye.
Bye-bye.
Bye.